So I'm going to talk to you about an adaptation we had to make to a debriefing model we were using with the HCOL students who came to us. I'm going to start with a summary, just in case everyone's losing the will to live. So this is what I want you to take away from this. Simulation can be great. It's great for learners. In our trust, it's also great for patients and carers, and I'll come on to explaining how that is the case. And it can also be great for facilitators. So I absolutely love facilitating our simulation. But it's really important that we have a model for facilitation that meets the learning needs of the learners, but also is acceptable to the facilitation team. I guess it's that we're going to talk about it. Who is not familiar with simulation? You all kind of aware? Yeah, okay. It's new in psychiatry. We've only been doing it for a few years, but so participant goes in, gets filmed, comes out, and is debriefed, and then the group is debriefed. Okay, great. So, what we've developed in Nottingham is this thing called Coproduced Psychiatry. On my way in, I noticed all of the snazzy models that you have. So we don't have that in psychiatry because we deal with people. So we have to. Yeah, I know you all do as well, but with emotions and feelings, and we can't do that through AI just yet. So we've had to come up with a way of emulating that. And what we do is we employ a series of amazing actors. Some of you might have met some of them. If any of you have trained here, you probably will have done. And what we do is, so we've developed this over several years, and we co-produce our scenarios. So we involve people who have lived experience of being mentally unwell, and we all come together with clinicians. We have a medical educationalist who hopefully keeps us on track that we're not going too off-piece, but also the actors and the wider MDT. And that's how we create our scenarios. So it's actually quite involved, and it's quite expensive, but it's probably cheap compared to the models. So, and learning outcomes are contributed by each of those stakeholders. Obviously, we have the overview of what we really focus on, but the patients give us outcomes of what they want doctors to know. And we've had really good feedback. People say, so we've just completed regional F2 teaching for all of the F2s in the region, and it's been really good. So it's very realistic, apparently. So that's the context. We were then asked to produce something for the HCOL students and derived our clinical learning outcomes from the usual places and came up with a challenging consultation. Now, I think this would be challenging for anyone, actually. So you've got an older, confused person brought into A&E by police, found wandering, and then the daughter arrives in a state of heightened anxiety. So the students need to not only manage the clinical aspects of the case, so differential diagnoses, possibly a cognitive assessment, mental state, but also the flow of the consultation with a confused patient and a distressed relative. So it's actually quite a big ask. Our facilitators, our lovely facilitators, two of them are sitting over there. So we have some amazing clinical nurse educators. Have I got that right, Julie? Okay. Who've had some training in debriefing using a particular model. So the model we use in the trust, which is the diamond model, and also our wonderful HCOL consultant. So that is who was going to be facilitating the simulation. Is anyone familiar with the diamond model? Yes, I'm seeing some nods. Okay, there isn't time to go into it, but it is a model that has an evidence base in particular kinds of debriefing situations, and it mainly focuses on the non-clinical aspects of the consultation. So what sometimes is termed the soft skills, communication, team working, interaction. So off we went with our wonderful co-produced scenario. and had the first few students go through it. And very soon we started to get feedback from the facilitators. Actually, this model isn't really working for us. We're not really finding it that helpful. The students require clearer guidance on how to approach the clinical reasoning, and I think that last lecture really spoke to that, actually. That they hadn't yet developed the clinical reasoning skills to go into that situation, because who does on day one, right? And so the facilitators wanted more guidance on when and how to incorporate the didactic teaching elements that arose throughout this. So we kind of went back to the drawing board. We had a meeting with the facilitators and really tried to understand what the problems were from everyone's perspective, and came up with some changes. So we introduced a clinically orientated small group discussion before sending the poor student into this clinical scenario that we would then have when they came back as well. And we also, so one person would volunteer to be a scribe and take the clinical history. So basically what we were trying to do was to get them to collect the clinical information and put it into a framework that helped them make sense of it, which is what most experienced clinicians do automatically. So this is what we've ended up with now. So before the simulation, we have the vignette, we discuss it at a whiteboard, we come up with a list of differential diagnoses, and we come up with a list of, well, what are you going to do now? What's the most important thing to go in and do? Once that's all agreed by the group, the brave volunteer goes in and does the simulation, while the scribe in blue is busy jotting everything down and everyone else is watching. They then finish, come bouncing back, we go back to the whiteboard, jot down any other clinical information and clarify any points before then going into the individual debrief, which then turns into the larger group debrief. So that again is far more like the usual diamond model. So we did this isn't a study, this is just what was happening, but we thought we'd better survey actually how this has gone down and has it made a difference. So we did a survey after we introduced these changes. All the facilitators agreed that actually we were now meeting the learning objectives. There's only 5 of them, but it's good. And importantly, they all enjoyed facilitating the course. That kind of group discussion, group facilitation, because it's very much a social constructivist model when we get into the learning during the discussion. And actually, if the facilitators don't feel confident and comfortable, then the discussion doesn't really happen. So that is really important. The students also agreed that the simulation was relevant and helpful. And actually, in the free text response, they said it was the discussion before and after that was particularly good. And they would all recommend it to a peer, so that's also a relief. So in conclusion, we learned, and I know you guys probably know this because you've been doing it for decades, but we've learned that the success of simulation really depends on finding or creating a debriefing model that works for everyone. And that's it. Thank you.